Okay, welcome everybody to our webinar. My name is Охад Толедано from Alma's Clinical Department. We're very happy to host you here today in our laser basics seminar. This webinar was initially performed for our Indian audience, and there was a big demand, and it was a big success. So we were asked to perform this another session for our Latin audience, and I see many of you here today. Emiliano, I see Dr. Jaime Piquero, a lot of you, so it's very nice to see familiar faces and names. I hope you'll enjoy this webinar. This is a pre-recorded webinar. My part was done a week ago, so I'm referring this to one of my colleagues who was doing the second part, which was the laser skin interaction. And this part today will be done by our VP Clinical Department, Mrs. Hannit Brенner. And the third part will be done by Naama Cohen, our clinical application specialist in APAC region. So I hope you enjoy, and during our lectures, you can write your questions on the chat and we will try to answer them at the end. So there you go, good luck. So starting at the basis, in our field, we have different sources of energy that are used to treat. And we're going to discuss lasers today, but we also have intense pulse light, or IPLs as they're referred to. There is treatments with radio frequency and ultrasound. All of those can be used for aesthetic and dermatology purposes, but we're going to focus on laser today. So what is laser? Laser is actually a light. It is an electromagnetic radiation that is acting like a wave, but is made of particles. The speed of light is very fast, as you might know. It's about 300,000 kilometers per second, okay? And many people are mistakenly thinking that the visible light, or the light we see, is the only one light existing, but we're gonna talk to you over that in a while, and explain that the light is much more than what meets the eye. Actually, the visible light is a tiny portion of the spectrum, and the spectrum is what we refer to as the electromagnetic spectrum. The electromagnetic spectrum is a very wide one, including many types of radiation, from very harmless, harmful radiation that ionizes, going to the UV light, and in the far region of the safety profile, we have the microwave and radio frequency, which are also a part of the electromagnetic spectrum. This is the electromagnetic spectrum, as you can see. And as I told you before, if you look at the left side of the diagram, we see here the gamma rays, okay? Very short wave. And the shorter the waves are, the more energy it has stored in it. So gamma rays, being the shortest one, are very dangerous because they can inflict damage to the DNA. Moving on, we have the X-rays, again, relatively energetic and dangerous electromagnetic radiation. Then we have the UV. The UV is mostly dangerous, as you are familiar. A lot of the radiation coming from the sun is UV, UVA, UVB, and UVC. The C-type and B-type are the more dangerous one, and the UVA is considered relatively safe depending on the doses. And you can see that the portion of visible light we see here is a fraction of the entire spectrum. Some ranging from about 400 to 800, we have the visible light. And moving on, we have the infrared, near, mid, and far infrared region, which is used in many cases in technology, which is a bit safer. And follow that, we have the radio wave, which is of longer wavelength, making it a bit more safe. So I was referring to what is light. Okay, light is actually particles moving in a wave shape direction, or in a wave shape pattern. It has actually a dual definition. The particles in this case are photon. They store energy within them, and they move like a wave. Now, when I was talking in 2 slides before about the wavelength, you can see that, like I mentioned, the light moved by wave, and we talked about the energy being more absorbing, more energetic or less energetic, and then being more dangerous or less dangerous. We have different way of, I would say, classifying, and each wavelength has its own unique characteristics. When we talk about the differences between peaks of this wave, okay, this is how we measure the wavelength, okay? This is usually measured in nanometers. If we're talking about the far right side of the spectrum, we're talking about hertz, but usually it's referred to in nanometers, and the amplitude is referring to the stored energy in it. Now, in shorter waves, we can see that it's, like I mentioned before, are the peaks in between, the gap between the peaks is shorter, making more potential energy stored in it and making them a bit more risky. Now let's discuss about laser. How is laser formed? What is laser actually? And if you didn't know, the laser is actually an acronym that stands for light amplification, stimulated emission of radiation. Okay, so it's not a word, it's an acronym. And let's drill down and try to understand what exactly is a laser. So laser, first we have to understand photons, okay? Photons, it's actually comprised of electrons, okay? The atoms are made of electrons, protons, and neutrons. You can see in the middle, we have the protons and the neutrons, and the electrons are moving around in orbit, and all of those, they create the atom, okay? So it's a very stable, natural state of every matter in nature, okay? What happens when we excite those atoms, okay? So there's a different kind of excitation. And as I mentioned, the electrons or the atoms are usually in a resting stage, but sometimes they can be triggered, okay? If there is an energy emitted from the outside that causes them to stimulate or to get out of this resting state. And what happens is they bounce into their higher level of orbit, okay? And then they can rest, and then they can return to the resting state on their own, okay? So this is called spontaneous emission. Spontaneous emission is when an atom is excited into a higher level of energy, okay, moving to a higher orbital, and spontaneously releases back into its natural state or its steady state. When this happens, the energy that it was stored in the excited state is being released in the shape of a wave, okay? And this is what, and the return to a stable state releases some energy, okay? And in the, like we mentioned, spontaneous emission is ultimately responsible for most of the light we see around us. So this is a situation that goes back and forth constantly. This is not what happens in lasers. When we talk about lasers, we're actually trying to stimulate the laser, okay? I would say artificially, trying to create more arousement of the atoms into their excitated state. And then we also have to amplify them, but this will be the next step. So an excitated electron, if it absorbs another photon, it becomes more energetic, goes to another higher level of state, I would say, with the same energy, direction, and the same wavelength. So these are actually aligned. But when falling into the resting state, it releases those atoms, okay? And this is what we refer to as stimulated emission, okay? When we create enough of this stimulated emission, we're actually creating amplification, okay? We're causing a lot of atoms to excite to the point that we're generating a lot of energy that can be later on released simultaneously as a laser pulse, okay? Increasing a stimulation of photon leads to an environment where more than 50% of the atom are excited. Okay, this is called population inversion. We'll talk about that in a second. And this is compared to the resting state. This situation of the population inversion is what generates and operates inside the laser. This is an illustration of how the stimulated emission looks like. And just to summarize all the steps we've seen so far, so consider that this is how an internal part of the laser look like. We'll discuss it in a second. Most of the atoms in the medium we use are in a resting state. When we emit enough energy, okay, we're causing some of those atoms population to be energized to another higher level of energy. Okay, this is the population inversion, followed by a spontaneous emission, meaning that one atom begins to trigger this chain reaction of emission, and it amplificates. It amplificates to a stimulated emission to the point that the amplification is so intense that one of the mirrors in the laser that we will discuss in a few seconds just causes the excitation of this laser out, and this is the laser that we see at the end. Before talking about how is the laser comprised of, we need to understand what are the laser properties. What differentiate laser from a normal light? So these three characteristics are what separates laser from a normal light. First of all, it's monochromatic. Monochromatic means it has one wavelength, as opposed to normal light, the light we see on a daily basis. Even the most simple light bulb has a spectrum of light. IPLs, for example, also have some spectrum of light, so by definition, they're not lasers. The second thing is coherent, okay? That means that all the waves are in phase. They're moving at the same direction and in the same tempo, okay? As opposed to the light, which is incoherent. They move separately, they're not aligned, they're not in phase. And this, again, differentiate and makes it a non-laser type. And the last one is collimation. The laser moves from point A to point Z, okay? It doesn't diffract, it doesn't divert. So it is, again, the last property of laser, of collimated option versus divergent options of the normal light. It doesn't spread out throughout the space. Okay, so like I mentioned, the monochromatic is a single wavelength rather than a spectrum. In many cases, people tend to think that if a laser doesn't have any color, then it's not a laser. And we know now that it's not true. We have lasers in the UV area. We have lasers in the near-infrared region. We were talking about the coherence of the laser, meaning that it is phase. Ordinary, there is a mixture of different frequencies when we talk about incoherence, but when it's coherent, it's the same wavelength for all those waves, and all the particles are moving simultaneously. And collimation, like I mentioned, that the laser travels in a single direction from point A to point Z without spreading out into space too much. So now that we learned the basics, we need to understand the drill that we need to go and drill down about what we've talked about. So when we talk about the wavelengths, okay, usually I think the raw way to classify a laser is first and foremost by its wavelength, okay? We tend to differentiate the lasers by their wavelength, and then as you can see, throughout the spectrum surrounding the visible light, we have a lot of potential wavelengths that depend on the medium in which it holds within the laser. To understand that, we need to understand why do we need all those wavelengths, okay? So this is something Dr. Preeti will drill into, okay? Understanding that when we talk about our medical field or aesthetics or dermatology, we have different targets in which for each target we will need a different wavelength, okay? So you can see that the main targets here are melanin, hemoglobin or oxyhemoglobin, and water, and for each one of them there is different absorption in different wavelength. And this is one of the best ways to choose the proper wavelength to the proper indication that we want to treat, and Dr. Preeti will elaborate on that. She will also discuss more about another feature of the laser, which is the penetration to the human skin. Different lasers have different penetration to skin. Okay, you can see here that roughly the maximum penetration is something around 1100 nanometer, somewhere around the Nd:YAG region. You can see that it penetrates really deep to the deep dermis. Again, depending on the area treated, depending on the water content of the skin, of the melanin content of the skin, there's a lot of parameters to take into consideration. But given that at the same skin type, different wavelengths penetrate differently. This will be discussed by Dr. Preeti. So let's talk about laser. How does the internal part of the laser work? And here I have to differentiate between a real laser, okay, or what we call a solid or a solid state laser. It's not always solid, but a real laser from a diode laser. I'm going to discuss about the actual lasers before discussing about the diodes. And in order to have a real laser, you need to have these four components. First and most importantly is the laser medium. The laser medium, which is inside the laser itself, determines what will be the wavelength. Okay, you can see it here at number 1. We have an internal part within the laser, and the medium can be either solid, it could be liquid, or it could be gas. And each one of them will give us a different wavelength. In order to excite the atoms of this medium, we will have to have some kind of an energy source or a power system outside of the laser to trigger this chain reaction. And this is what we call the power source. The power source could be RF, it could be another laser, it could be light, it could be electronic. There's various ways of creating stimulation of the atoms of the medium. We also have to have this important structure of an optical cavity, meaning that the laser from both ends has reflecting mirrors. One of them has to be fully reflective and the other one should be semi-reflective. This helps the atoms of the medium when they're excited to go back and forth and cause this amplification that we were talking about earlier, to the point that the laser is very energetic and is so-called ready to go out and is being released from the partially reflective mirror. Okay, when we get to a critical point. And from that point on, after being excited and amplified to a certain step, we can release it out of the cavity into a delivery system. The delivery system could be anything from an articulated arm, a fiber, lenses, micro manipulators. There is a lot of types of delivery systems. So when drilling into each one of them separately, as I mentioned, the laser medium could be gas, solid or liquid, okay? I assume most of the common lasers you're familiar with them are solid, producing the Nd:YAG, erbium-YAG, ruby, alexandrite, erbium glass, etc. These are solid, meaning that there is a crystal inside the laser. Another common laser is the CO2, for example, which has a tube of gas mixture in it, and one of the gases is CO2, or krypton or argon, and we have liquid-based medium, which are called dye lasers. These are the real lasers. In another direction, we have a production of lasers being done artificially, or I would say as non-real laser. These are the semiconductors, or what is familiar as diode lasers, okay? Sometimes it's being referred to as LED, LED emitting diode, okay? Light emitting diode. So what's the difference between those two? We'll discuss in a second. Going back to the next part, okay, we have the power source. As I mentioned, the power source that emits those atoms could be electronic, RF, it could be another flashlight, or it could be a different laser. And the optical cavity, you can see we have two mirrors. One is reflecting always, and the other one is partially refracting, where when we're doing excitation, at one point the laser will exit this cavity into the fourth option, which is the delivery system. Okay, the delivery system could be an articulated arm, could be an optical fiber, micro manipulators, or any other handpiece you can think of. Now, what is a diode laser? Up until now, we were discussing about those so-called real lasers. Okay, in a diode laser, the mechanism behind how is the laser created is quite different. Okay, this is an electronic component actually. That the main important part of it is called a PN junction. Okay, the PN junction is an electronic junction that allows the voltage to go back and forth from plus to minus and causing this excitation. Okay, now there is a cavity, a small cavity inside the diode that its partially reflecting surface will cause the emission of the laser at the end. Okay, so in a laser diode, the photons are bounced back and forth in a small microscopic junction. If we supersize it, you can think about it just as the cavity we were discussing before. And between those P-type and N-type semiconductors, and eventually it will be released. Okay. Now, the fact that these lasers are being produced differently than real lasers causes a differentiation between the options, or I would say the abilities of those lasers. And as you can see here, the advantages of the real laser diodes, okay, of the diode lasers, is that they're relatively cheap and they're simple construction. That also makes them smaller in size and lightweight. So this is a good and important advantages. It's highly reliable as compared to other lasers, long shelf life, high efficacy, and low power consumption. So it has many advantages. Okay. On the other hand, it has some disadvantages that make, I think, in most cases, people select the real diode lasers, or actually it's depending on the indication that you treat. But one of the disadvantages of the diode laser is that it's not suitable for application when high powers are needed. And I would say also that when you have to have a very short pulse duration, the diodes cannot create that. And it's also highly dependent on temperature, meaning that if we are working a very long procedure, okay, the diode has to be intensely cooled in order to work, and it could fail more easily than the laser itself. So what types of laser and what are the characteristics for each lasers? This is the main issue. So we can classify lasers by different means. We can classify them by the way they laze. For example, we can talk about continuous wave lasing, like you are familiar with a CO2, or we can talk about pulse wave lasing that happens in most lasers that we are familiar. This really differentiates between two types of laser. We can also talk about an ablative versus a non-ablative laser. Again, Dr. Preeti will drill down into this feature, but on a nutshell, ablative lasers cause evaporation of a tissue versus the non-ablative lasers, which cause heating of the tissue to the point of destruction, but it will not evaporate any tissue. We can also differentiate lasers by being a full beam, like you see here on the left, or by becoming a fractional laser. Okay, taking the same laser beam and doing some manipulation on it to make it from a full beam to a micro beam pattern. Again, this is something that Preeti will discuss later, but again, this is a kind of classification that the laser may have. Now, lasers may be pulsed or non-pulsed, fractional or non-fractional, ablative or non-ablative. So almost all the options and the combinations are available. Here you can see some of the histologies. Oh, I missed one, of how does the type of laser look like, but again, this is Preeti's part to discuss. And when we talk about the laser parameters, these I think are the four most crucial parameters of the laser, not the only ones, but the most crucial ones. Like we mentioned, the wavelength differentiate our laser far most, okay, but many people are not aware that another very crucial laser parameter is the pulse duration. The pulse duration has a lot to do with how the laser will react on the skin. And again, this is for Priti to discuss. We also need to talk about the fluence or the energy in that laser and about the spot size. In what area are we lasing our laser? So the wavelength, we've discussed that. It determines, it is determined by our medium. It could be liquid, gas, or solid, as I mentioned. It's aimed for a specific homophobe. For example, if you take the Nd:YAG, which is maybe the most common laser, you can see that Nd:YAG absorbs both in melanin and oxyhemoglobin and water. But if you take those shorter wavelengths like alexandrite, so it is absorbed in melanin and oxyhemoglobin, but no absorption all in water. So this really helps me decide which laser do I need to use according to the absorption. The second parameter, like I mentioned, is the penetration. We need to know that if we're targeting a specific target, we have to know, will we reach it at the end? Pulse duration is another crucial factor. We can have pulses in milliseconds, microseconds, nanoseconds, and even picoseconds, okay? The shorter the pulse, the more aggressive it is, okay? And if I prolong my pulse, I'm actually cooking the tissue in this case, so we're getting more thermal effect than an aggressive immediate effect with high peak power. Here you can see the differences between the optional pulses in lasers today. We have the millisecond, which is called long pulse. It's 10 in the power of -3 with a thermal effect. We have the microsecond, 10 in the power of -6, which is a thermal effect. We have the nanosecond, which creates us a photoacoustic effect and a mild thermal effect. And we have the picosecond, 10 in the power of -12, that gives us laser-induced optical breakdown and photoacoustic effect. Another important issue is the thermal relaxation time. Okay, the thermal relaxation time is not a parameter of the laser, it's a parameter of the target that the laser is aimed to, but it's important to us to know the thermal relaxation time of the target in order to select our proper pulse duration. So the thermal relaxation time, or TRT, is defined as the time needed to remove 60% of the heat, of the temperature that this target has reached at its maximum. So if I've reached, for example, 100 Celsius degrees, okay, so the time needed for me to remove 63 degrees, coming back to 37, will be my thermal relaxation time. And as you can see on the table on the right, different targets have different relaxation time. We're talking about tattoos, melanocytes, blood vessels of different types, hair follicles, etc. Again, this is something for Priti to discuss furthermore, but we have to understand that in order to select the proper pulse duration, we have to take into consideration the TRT of our target. Fluence, or energy for that matter, is an important feature, okay, to know when we're going and treating with the lasers. Fluence is measured in joules per centimeter square, meaning that this is the energy per area, okay? So it's not only about how much energy I deliver, it's about how much area am I delivering it in, okay? As for the fluence increases, so that the destructive force of the laser, okay? And the relationship between the fluence and the area, in this case, the spot size, is very, very, very crucial, okay? And in order to understand that, we need to talk about those spot sizes, okay? Spot size is the diameter of the laser being emitted, okay? And when we change our diameter, we're actually changing some of the laser properties. This is why it's another very important factor of laser. The larger the spot size, the deeper the penetration, okay? There is more absorption and less reflection of the laser. Why does laser reflect? I will allow Dr. Priti to explain more thoroughly in her presentation. But at this point, we have to know that the laser doesn't absorb 100%. Some of the laser is being rejected and reflected. And the bigger the spot size, the less reflection back we have, and that means that there is more absorption of the laser, making it more effective. It also has a stronger clinical reaction. It makes the laser more effective if we increase the spot size. It also covers the treatment area much faster. And in higher fluences, paradoxically enough, when we switch to higher or bigger spot size, we actually need to reduce the fluence, and this is because what I've talked before, that we're getting stronger clinical reaction. If I want to be safer, I will need to decrease the energy slightly when I increase the spot size. Okay, this is sometimes very hard to understand, but it's a crucial key to understanding the relationship between the spot size and the fluence. Okay, so this is the basics about laser. I hope that pretty can enlighten you all. I just want to give you a few minutes about the safety because it's very crucial, especially in these days. Laser safety is very critical, okay? We have actually two ways of looking at the safety. First of all is the safety of the patient, but we also need to consider about the safety of the practitioner or anyone who is in the room who is not the patient. If we're talking about the patient, we have to discuss about his skin type because we're addressing the skin, and different skin type will react differently to different lasers. This is why it's crucial to perform skin test on any procedure you think about doing with laser. This will, if you perform a skin test, this will probably let you off from 80% of your adverse effects. If you do a proper skin test and follow the indication, the parameters from those skin tests, you will avoid any complications. Cooling is another feature that can help you when we're talking about skin of color. And of course, post-treatment care should be taken. But when we're talking about general safety issues, first of all, not many people know that, but since we talked, there is a reflection from the laser. There shouldn't be anything in the room that reflects back, such as mirror or windows. So we should be covering every window that we have, and we should avoid using mirrors in our laser room. Laser science. Since most of our lasers are classified as laser type 4, okay, they are harmful to vision, they're harmful to eyes, so we need to be extra cautious, and at the door tell whoever wants to enter that laser is being used, so we have to signal it and sign it properly. Like I mentioned, most of our lasers are classified as a class 4, direct and reflected back, so we need to take that into precautions. As you can see, most of the injuries are eye injuries. About 70% of the cases of the damage caused by laser reflects on the eye. Why? Because the eye has chromophore, and the chromophore absorbs this laser, okay? And the damage could be potentially the one that can be restored later on. Another option is to have some skin injuries, electrical accidents, any malfunction of the devices, and in some cases even fire hazard or fumes. So how do we protect the eyes? As I mentioned, we have reflection, we have direct eye contact, and we have scattered laser that can happen, and the best way to protect ourselves is with those goggles, okay, with eye protection. This is a must. It's a must not only for the practitioner, but to whomever is in the room at that point, okay? Of course, that the patient should also have eye protection, and if we're treating the face, it should be an opaque, okay, goggles. And it's very important to understand that different eyewear has different wavelength. Before starting the procedure, you have to know which wavelength are you working in, and you have to know what is the proper goggles to protect you from that wavelength. Okay, so the goggles have to be in correlation with the wavelength that you're working on. Our laser has to be in a standby mode at all times, unless for the time that we're emitting it, okay? So please keep that in mind. We don't want to be pressing the foot switch in the middle of the lasing or at the middle of the ready state. If the laser is not actively working, place it on standby. Okay, if needed, there is always an emergency switch. So this is my Laser 101. Thank you for attending and listening.
Hello, everyone. It is a pleasure to be with you all here. My name is Hanit, and I'm the VP of Clinical Affairs at ALMA. I will start by discussing with you skin aging process and different treatment approaches. And then I will ask Naama from our clinical team to join, and she will dive in depth into laser tissue interactions for the different applications and more. I'm sure you are all familiar with skin anatomy, but still I wanted to say a few words on the different layers of the skin just to make sure that we are all on the same page. So let's start. The skin in general is divided to 3 different layers. The outer layer is the epidermis, in the middle is the dermis, and below it the hypodermis, which is also known as a subcutaneous tissue, and contains mostly fat and connective tissue. Today we will focus mainly on treatments that target the epidermis and the dermis, but obviously laser can also treat fat and other tissues as well. If we will have a closer look using a microscope, we will be able to see that the epidermis is composed of 5 distinguished layers, and that the majority of the cells in the epidermis are keratinocytes that secrete keratin. In addition to keratinocyte, there are some melanocytes that secrete melanin, which give the skin its color, what we refer to as skin type. In the dermis, we have the extracellular matrix, which is like a glue, or we can even say like a gel that connect between the fibroblasts. And there are different components in addition to this glue, such as hair follicles, subcutaneous glands, blood vessels, nerves, and more. I wanted to share this beautiful photo taken with the microscope, in which the different components in the extracellular matrix were marked with specific fluorescent marker. In blue, we can see the fibroblasts that secrete and organize the extracellular matrix fibers that are loaded with growth factors complexes, which are marked in green. The overlay resulting in the turquoise color. The fibers inside the cells are visualized by detecting a smooth muscle protein and are colored in red. Cells nuclei is visualized in yellow. And actually, this is how a young, healthy extracellular matrix looks like. Now let's see what happens as we get older. Actually, as the body ages, the appearance and characteristic of the skin change. Collagen and elastin deteriorate and cause the skin to become thinner and eventually sag. Here is a list of components and activities that are reduced or decline with time. These changes will result in skin deterioration. So, what do we want to achieve? What is the goal of skin treatments? Actually, it is quite simple. We want to have a younger look by having a homogeneous epidermis with no pigments, no redness, blood vessels, spots. And we want to have a very organized and young dermal extracellular matrix in the dermis. Treating both the extracellular matrix and the epidermis will result in overall smoother and tighter skin appearance. At the beginning, more than 20 years ago, laser treatments for skin rejuvenation were very aggressive, mostly full ablative CO2 laser treatments. These treatments were extremely effective, but they were correlated with very long downtime and many complications, such as scarring and infections. This led to the appearance of non-ablative treatment modalities, actually usually using RF devices that were based on gentle tissue heating in order to create dermal heat stimulation. And indeed, these treatments had low side effects and no downtime or almost no downtime, but they also lack efficacy. This led to the appearance of the fractional approach. We can see here some examples for fractional treatments. Fractional means that we only treat fractions of the skin. We treat in very, very tiny columns while leaving a healthy tissue in between the treated zones, so the injury is quite minor and the healing process is quicker. The treated zones can be either ablative, meaning the tissue is evaporated, or non-ablative, meaning the tissue is only coagulated. The cells are dead, and they will be removed using the immune system, and this tissue will be replaced with new healthy secreting cells. This is an example in which we can clearly see the difference between full and fractional laser treatment. This is an example, these photos are for CO2 laser treatments. We can see that the full treatment is very aggressive and the result and results in a long downtime. While fractional treatment is less aggressive, less dramatic, and is more acceptable by patients. Less downtime, less complications, while still we maintain good clinical outcome. Usually the effect of lasers on skin relates to heat or heating. There are other effects such as photoacoustic effect and more, but most of the laser or the damage created by the laser is by heat. If the tissue is heated up to or between 80 and 100 Celsius degrees, it will be ablated. If the temperature will go up between 50 and 80 Celsius degrees, then we will be only coagulating the tissue. We can see here in the histology that the tissue is, some of the tissue is evaporated, meaning ablated. Then we have the coagulated zone marked in pink. If the tissue is only heated between 40 and 50 degrees, then the cells will be only stimulate to promote tissue remodeling. Actually, no matter how we damage the tissue by heat or by any other mean, the body will always react with a wound healing response. The body will react in accordance to the injury, meaning aggressive injury will evoke massive inflammation and vice versa. In order to repair the damage, the tissue needs to regenerate, the cell needs to grow and replace the lost tissue. In addition, the tissue needs to regain its function. For example, to reestablish blood flow. If we want to look generally at the healing process, we can refer to two main paths. The path on the left refers to an immediate effect in which the thermal injury actually denaturate collagen fibers immediately, which leads to collagen shrinkage and to a smoother immediate phenotype. The second path, the main path on the right, involves wound healing response, which cause elevation of growth factor and different cytokines, and to the induction of stress proteins. This initiates a cellular signal transduction cascade that will eventually change gene expression of different genes, matrix metalloproteinases, collagen formation genes, and more. This will result at the end in collagen remodeling. Actually, it takes between 3 weeks to 3 months. And this collagen remodeling and extracellular matrix remodeling will result in a smoother skin. Overall, at the level of the epidermis, the inflammation caused by the injury will result in keratinocyte proliferation and repitalization. And at the level of the dermis, the inflammation will result in fibroblast stimulation and tissue remodeling. Altogether, this process will generate smoother skin at the epidermal and dermal layers. I will now welcome Nama from our clinical team. She will dive deeply into the parameters that influence laser tissue interaction. And I will obviously stay here with you and will be available at the end for your questions. Nama, please go ahead.
Hi, my name is Nama, and I'm a clinical applications specialist at Alma. I'm in charge of Asia Pacific in terms of the clinical aspects, and I'll be taking you through this next section. In this section, we'll be going over laser tissue interactions, laser targets in the skin, and we'll briefly touch on the treatment options we have available to us. With lasers, our goal is for the laser light to be absorbed by a specific target. When our target molecule absorbs a photon, the energy from the photon is transferred to the target molecule. This is ideally where we want the laser energy to go. However, not all of the energy is absorbed by the target. There's also reflection, transmission, and scattering effects of this energy. Reflection is when the laser does not penetrate the skin, rather bounces off while there is no interaction within the tissue. Scattering occurs when the light has passed through the superficial layers of the skin, and it can be scattered in different directions within the tissue. Transmission is light that has not been reflected, absorbed, or scattered. Rather, it passes through superficial tissues and interacts with deeper areas, yet not absorbed by the target. There are different types of laser tissue interactions that can occur. We'll be focusing on two main effects, the photothermal effect and the photoacoustic effect. The photothermal effect is the most common effect we get with our lasers. This is when the laser light is absorbed by a chromophore in the skin and is converted into thermal energy or into heat. The skin's reaction in this case will depend on the temperature reached within the target, and the effects can be heating, coagulation, or vaporization. Another laser tissue interaction is the photoacoustic effect. This reaction happens within the chromophore when high energies are absorbed at short pulse durations. This leads to quick thermal expansions of the target and leads to shattering or destruction of the target. For example, destruction of pigmentation. In order to achieve the best results with our lasers and the indication we are treating, there are a few things we need to consider in order to have the optimal outcome. Our patient's skin type, the chromophore, the wavelength to use, the suitable pulse duration, TRT, which stands for thermal relaxation time, the laser spot size, and using the correct fluence. And we'll explain each of these briefly. Firstly, we need to consider the patient's skin tone. This is done using the Fitzpatrick scale, which ranges from a skin type 1, which is the fairest skin type, to skin type 6, which is the darker skin type. The scale is based on the patient's skin features and also their response to UV light. The parameters we choose for the different treatments will be largely dependent on the patient's Fitzpatrick skin type. Next is the chromophore we are treating. There are three main chromophores that we aim at: melanin, oxyhemoglobin, and water. As you can see in this graph, each chromophore has its own curve and absorption peak. This details how effective the chromophore will be absorbed with each wavelength. For example, if we look at the 500 nanometer wavelength, we can see there is a high absorption in melanin and oxyhemoglobin, and no water absorption. However, as the wavelengths increase, we can see less absorption in melanin and changes in water absorption. The wavelength we use is extremely important, as it is aimed at the chromophore we are intending to target. For example, if we use a 755 nanometer wavelength, we can target vascular pigmentation and the melanin in the hair. Another important factor with wavelengths is that the longer the wavelength, the deeper it penetrates, which is true up until about 1,200 nanometers. And this is also something that needs to be taken into consideration when choosing which wavelength to use. The pulse duration determines how long the skin is exposed to the laser pulse. This can be continuous, or it can be in pulses of milli, micro, nano, or picoseconds. In general, the shorter the pulse, the higher the peak power. TRT stands for thermal relaxation time. It's defined as the time needed for a specific chromophore to dissipate or to lose more than half of its temperature, around 2/3 of the temperature. In order to achieve the necessary heating in the target, the energy needs to be contained rather than lost to its surrounding tissues. This means that the delivery time must be faster than the target's thermal relaxation time, and this is often proportional to the size of the chromophore. The spot size refers to the diameter of the beam emitted from the laser. The larger the spot size, the bigger the area you can cover per shot, so the faster the treatment will be. In addition, the larger the spot size, the deeper the penetration due to the scattering of the laser light. A smaller spot size will be more superficial in terms of penetration. In addition, the smaller the spot size, the more aggressive the treatment will be, as there's more energy concentrated in a smaller area. Lastly is the fluence. Fluence is the optical energy delivered per unit area and is measured in joules per centimeter squared. By increasing the fluence, we will be giving more energy, so the treatment will be more aggressive. As the spot size is the unit area we are using with lasers, the relationship between fluence and spot size is key. To summarize the parameters we need to consider for treatments, we choose the wavelength we want to use based on the chromophore we are treating. The longer the pulse width, the lower the peak energy, meaning a milder treatment. For the spot size, the bigger the spot size, the quicker the treatment, and the deeper the penetration. And lastly, the higher the fluence, the more aggressive the treatment. Let's now look at the different laser targets we have in the skin and what we can treat. The main tissues that we target with lasers are as follows. There are vascular lesions, for example, leg veins, or the red veins that we can sometimes see on the face, or rosacea. The mechanism of action for vascular lesions is to close off the vein by coagulation of the vein and collapsing it so the blood has to find a different path to travel through. For pigmented lesions, the pigment is when the pigment is from melanin, for example, freckles or sun damage, the mechanism of action is to deliver a short pulse to shatter the pigment into small particles that can then be removed by our immune system. Tattoos, the pigment here is the tattoo's ink, and the mechanism of action is the same as the melanin pigment, to shatter the pigment so our body can remove the particles. For laser hair removal, our target is the melanin in the hair, and our aim is to deliver enough heat to the hair bulb so that it damages the root of the hair, enough to not allow for regrowth. Skin rejuvenation is a very sought-after treatment, and there are different types of techniques and options. Some treatments have very little downtime, and they create tiny little micro wounds in the dermis to promote the wound healing response and neocollagenesis. Other treatments create coagulation in the dermis, which also promotes neocollagenesis. There are also ablative treatments, which have longer downtime, where both the deeper and more superficial layers of the skin are treated. Lasers can be classified into two groups, ablative and non-ablative lasers. Ablative lasers are usually more aggressive as they vaporize the tissue layers, whereas non-ablative lasers are usually less aggressive and the epidermal layers of the skin remains intact. Ablative lasers include erbium YAGs and CO2 lasers, and non-ablative lasers can be an ND-YAG laser or an erbium glass laser. When treating vascular lesions with our laser, our mechanism of action is selective photothermolysis. It's selective because we are targeting hemoglobin, so our wavelength has good absorption of this chromophore. The hemoglobin absorbs the laser light and turns this into heat and causes the vessel to collapse so that the blood can't flow through it anymore. Depending on the depth of the vessel, we usually use a 1064 nanometer wavelength for deeper vessels, or a spectrum of between 450 to 650 nanometers for the more superficial vascular lesions. This is an example of treating leg veins with our long pulse 1064 nanometer handpiece on our Harmony device. And as you can see, the results are really amazing. This is another example of treating a vascular lesion called Klippel-Trenaunay syndrome. This was treated with one of our IPL handpieces, also on our Harmony device. Its wavelength is a spectrum of 450 to 600 nanometers, which also has good absorption of hemoglobin. For tattoos, our mechanism of action is the photoacoustic effect. The laser is absorbed by the pigment in the tattoo, and due to the short and powerful pulses, which can either be nanoseconds or picoseconds, the pigment is shattered into small particles, which can then be removed by the immune system. Our chromophore here is the tattoo ink. Depending on the color of the tattoo, we select the wavelength. So a 1064 nanometers for the darker tattoos, black, blues, and grays. 532 nanometers for reds and oranges, 585 nanometers for blues and purples, and 650 nanometers for the different types of greens. In this histology, we can see the photoacoustic effect. We can see the bubbles that are formed from this effect due to the short and powerful pulses. This is an example of a tattoo removal treatment using our PicoClear laser. And after just 4 treatments, we can see a really nice fading of the pigment in the tattoo in a skin type 5 patient. For pigmented lesions, our mechanism of action is the same as tattoos, shattering of the pigment. However, in this case, our chromophore is the melanin in the pigment. For superficial pigments, we use the 532 nanometer wavelength, which has high absorption in melanin. And for deeper pigments, we generally use the 1064 nanometer wavelength. This is an example of superficial pigmentation that was treated with a 532 nanometer wavelength with our AlmaQ laser. And after 1 treatment, you can see how the pigment has completely disappeared. This pigmentation is deeper. It's a nevus of Ota and was treated with a 1064 nanometer Q-switched handpiece on our Harmony device. And after 3 treatments, you can see how nicely the pigment has faded. For hair removal, our mechanism of action is selective photothermolysis. Here our chromophore is the melanin in the hair, which absorbs the laser light and turns it into heat, and then spreads to the surrounding tissue to cause enough damage, mainly to the stem cells, so there's no regrowth of the hair. The common wavelengths used for hair removal are 755, 810, and 1064 nanometers. This is an example of laser hair removal using our unique Trio handpiece, which has the 3 wavelengths that lace together. And as you can see, it's effective and safe for all skin types. For skin rejuvenation, we can use different mechanisms of action depending on the results we want to achieve. There's the photoacoustic option, which is a non-ablative treatment that creates micro wounds in the dermis to induce the wound healing response and thus neocollagenesis. The photothermal effect is also a non-ablative treatment that creates coagulation columns in the dermis and also promotes neocollagenesis. Ablation creates microcolumns in the skin and also stimulates the wound healing process and neocollagenesis. The chromophore here is water, and the wavelength also depends on the type of rejuvenation treatment we are doing. It can be a 1064, a 1540, a 2940, or 10,600 nanometer wavelength. This is an example of a non-ablative rejuvenation treatment with no downtime using our fractional PicoLift handpiece. And as you can see, after just 4 treatments, there's a really nice improvement in the patient's crow's feet and in their skin tone. Looking at this ex vivo histology, you can see that the epidermis remains intact, hence no downtime, and the little bubbles that are formed in the dermis from the photoacoustic effect. These pictures are an example of rejuvenation using laser and the photothermal effect. And after 4 treatments, you can see a really nice improvement of the skin with no downtime at all. This histology was done using our new ProClear Skin 1540 nanometer handpiece. You can see the coagulation columns here created by the photothermal effect. With 3 stacks and 3 passes, we see a really nice dispersion of the heat to the surrounding tissue. Here you can see an example of an ablative treatment with our CO2 laser on the upper lip to treat barcode wrinkles. This treatment involves more downtime than the others, but as you can see, the results are worth it. These histology pictures are from our CO2 laser using the scanner. As you can see, we have nice ablation columns, as well as thermal damage surrounding the columns, which all contribute to inducing the wound healing response and to achieving the results that we want. As you all know, we have a wide range of technologies and lasers in our portfolio to treat all these different indications. Once we know how our lasers work and take everything we've gone through in the session into account, it will help us choose the right laser and to treat the indication correctly. Thank you all so much for your time and for listening.
Okay, so I hope you enjoyed this part of the webinar. Now we're moving to your question part. So we had some questions here. You can still write them down as we go along. We were asked if it is true by Sylvia. Is it true that lasers create aerosol effect? In this COVID era, what should we use when we perform laser, such as Q-switch, long pulse, erbium YAG, etc.? So I would like for Hannit to address that, but before that, I would say that generally, yes, we know that lasers do kind of exfoliation or not exactly aerosol, but there are fractions of the skin that can be removed during the laser treatment. Of course, that with ablative procedures, it's much more common. And with them, of course, you have to use mask, facial mask, you have to use fume evacuator and be very sterile. But also with the non-ablative, we know there is small portion of fragments released from the skin. And we should be extra careful now in these days. I assume you follow the news as much as me, and you see that in regards to this COVID-19 virus, there is more than meets the eye, and there is still a lot of uncertainty about exactly how this pathogen is being transformed from one person to another. So I say take the extra safety and cover yourself when doing any procedure. Hannit, would you like to comment on that?
Yeah, I think that you were very, very accurate. Actually, when we provide ablative treatments, and we always need to use the smoke evacuator, and we always need to wear a mask. This is the common practice. If there are small particles in the air, we do not want to heal them. And actually, as for the COVID-19, this is based on the local regulation. It means that you need to follow the the rules or the suggestions that are made by the local Ministry of Health. As for cleaning or sterilization, we actually stick to what we are providing in the user manual or the operating manual or the service manual. There is no specific cleaning or specific sterilization process for this virus. Just use the regular cleaning instructions. If there's still anything that you think that was not answered, just go ahead and ask more.
Okay, so we have another question from Medang. For laser safety, it's the same question about the fumes that created by the laser. We have a question by Michelle. How do you perform the skin test? We usually do patch testing prior to the treatment, but haven't done this yet. So basically patch test and skin test are the same. I think that the best option is to do the skin test a day or two before the actual treatment, but I know it's it's not possible in many clinics, and it's not even economically. So what I think should be is in the fair skin types, I would say skin type 1 to 4, I would do a test on the treated area with the lower part of the recommended settings of the protocol. I would do it in a small area just to see the skin reaction, and then you need to wait. In the fair skin types, you need to wait, I would say 15 to 30 minutes. And on the darker skin types, you should wait even more, up to 2 days, because there is prolonged potential damage to those darker skin types.
One more thing, maybe it's, I think that it's worth mentioning, always do the first pass or the test in a hidden place, like not in the middle of the cheek or at the between the eyebrows. Okay, just do it in an area which is less exposed. This is always a good idea, and at least wait few minutes to see the reaction, skin reaction. If it's too aggressive, at least for some of the treatments, you will be able to notice it.
Okay, we have another question from Michelle. Is it safe for skin type 6 to undergo ablative laser procedure like pixel or CO2? So I would like Hannit to comment on that because she's a CO2 specialist, but generally speaking, for skin type 6, I can say that the erbium YAG as an ablative laser is recognized and by the medical community as safe and effective for this skin type, and we have numerous results indicating that. The CO2 is more tricky, so I will allow Hannit to answer that.
Yeah, actually we prefer, with darker skin types, we prefer the erbium YAG. It is quite simple. It creates less heating, so there are less complications with the erbium YAG. If you have a lot of experience with the CO2, then you need to go with very, very low density with CO2, very, very, very mild parameters, but it is risky. You need to have a lot of experience. I've seen darker patients having a CO2 treatment, but this is more tricky. If you are not very well familiar with the CO2, obviously it is preferable to do the erbium YAG treatment.
Okay, so we get asked about sharing this presentation and sharing this recording. So our marketing team will send all the participants the recording later on this week or within a few days. And as for the presentation itself, it's not a controlled one. We haven't regulated it, so we will try and share it in the near future in our partner zone. So please keep that in mind. And we have an additional question about the CO2. What is the difference between injury created by a 50 watt CO2 or a 30 watt CO2? And again, Hannit, I think this one is for you.
Yeah, actually, it's quite simple. Since the peak power is higher with the 50 watt, you will be able to go much deeper. Usually, this is for scars treatments, so for treatments that you need to penetrate to have the columns very deep into the skin. We usually say that for regular skin resurfacing CO2 treatments, the 30 watt is more than enough. You reach about 1 millimeter, almost 1 millimeter depth into the skin in each column, and you can do it either with the pixel handpiece or with the scanner. So either way, you will have good results. With the higher power, with the 50 watt, you can just go deeper, be more aggressive. For regular treatments, usually it's not required. I hope it answered the questions.
Okay, so this sums up the question you had. I would like to thank first Hannit and Naama for taking the time and presenting us, and for you to attend this webinar. We hope to see you in our next webinar, and even to see you in Alma headquarters in Israel. Thank you very much. Thank you all for participating. Goodbye.
Thank you. Bye-bye.
Bye. We were asked if it is true by Sylvia. Is it true that lasers create aerosol effect? In this COVID era, what should we use when we perform laser, such as Q-switch, long pulse, erbium YAG, etc.? So I would like for Hannit to address that, but before that, I would say that generally, yes, we know that lasers do kind of exfoliation or not exactly aerosol, but there are fractions of the skin that can be removed during the laser treatment. Of course, that with ablative procedures, it's much more common. And with them, of course, you have to use mask, facial mask, you have to use fume evacuator and be very sterile. But also with the non-ablative, we know there is small portion of fragments released from the skin, and we should be extra careful now in these days. I assume you follow the news as much as me, and you see that in regards to this COVID-19 virus, there is more than meets the eye, and there is still a lot of uncertainty about exactly how this pathogen is being transformed from one person to another. So I say take the extra safety and cover yourself when doing any procedure. Hannit, would you like to comment on that?
Yeah, I think that you were very, very accurate. Actually, when we provide ablative treatments, and we always need to use the smoke evacuator, and we always need to wear a mask. This is the common practice. If there are small particles in the air, we do not want to heal them. And actually, as for the COVID-19, this is based on the local regulation. It means that you need to follow the the rules or the suggestions that are made by the local Ministry of Health. As for cleaning or sterilization, we actually stick to what we are providing in the user manual or the operating manual or the service manual. There's no specific cleaning or specific sterilization process for this virus. Just use the regular cleaning instructions. If there's still anything that you think that was not answered, just go ahead and ask more.
Okay, so we have another question from Dang. For laser safety, it's the same question about the fumes that created by the laser. We have a question by Michelle. How do you perform the skin test? We usually do patch testing prior to the treatment, but haven't done this yet. So basically, patch test and skin test are the same. I think that the best option is to do the skin test a day or two before the actual treatment, but I know it's not possible in many clinics, and it's not even economically. So what I think should be is in the fair skin types, I would say skin type 1 to 4, I would do a test on the treated area with the lower part of the recommended settings of the protocol. I would do it in a small area just to see the skin reaction, and then you need to wait. In the fair skin types, you need to wait, I would say 15 to 30 minutes. And on the darker skin types, you should wait even more, up to 2 days, because there is prolonged potential damage to those darker skin types.
One more thing, maybe it's, I think that it's worth mentioning, always do the first pass or the test in a hidden place, like not in the middle of the cheek or at the between the eyebrows. Okay, just do it in an area which is less exposed. This is always a good idea, and at least wait few minutes to see the reaction, skin reaction. If it's too aggressive, at least for some of the treatments, you will be able to notice it.
Okay, we have another question from Michelle. Is it safe for skin type 6 to undergo ablative laser procedure like pixel or CO2? So I would like Hannit to comment on that, because she's a CO2 specialist, but generally speaking, for skin type 6, I can say that the erbium YAG as an ablative laser is recognized and by the medical community as safe and effective for this skin type, and we have numerous results indicating that. The CO2 is more tricky, so I will allow Hannit to answer that.
Yeah, actually, we prefer with darker skin types, we prefer the erbium YAG. It is quite simple. It creates less heating, so there are less complications with the erbium YAG. If you have a lot of experience with the CO2, then you need to go with very, very low density with CO2, very, very, very mild parameters, but it is risky. You need to have a lot of experience. I've seen darker patients having a CO2 treatment, but this is more tricky. If you are not very, very well familiar with the CO2, obviously it is preferable to do the erbium YAG treatment.
Okay, so we get asked about sharing this presentation and sharing this recording. So our marketing team will send all the participants the recording later on this week or within a few days. And as for the presentation itself, it's not a controlled one. We haven't regulated it, so we will try and share it in the near future in our partner zone. So please keep that in mind. And we have an additional question about the CO2. What is the difference between injury created by a 50 watt CO2 or a 30 watt CO2? And again, Hannit, I think this one is for you.
Yeah, actually, it's quite simple. Since the peak power is higher with the 50 watt, you will be able to go much deeper. Usually, this is for scars treatment, so for treatments that you need to penetrate to have the columns very, very deep into the skin. We usually say that for regular skin resurfacing CO2 treatments, the 30 watts is more than enough. You reach about 1 millimeter, almost 1 millimeter depth into the skin in each column, and you can do it either with the pixel handpiece or with the scanner. So either way, you will have good results. With the higher power, with the 50 watt, you can just go deeper, be more aggressive. For regular treatments, usually it's not required. I hope it answered the questions.
Okay, so this sums up the question you had. I would like to thank first Hannit and Naama for taking the time and presenting us, and for you to attend this webinar. We hope to see you in our next webinar, and even to see you in Alma headquarters in Israel. Thank you very much. Thank you all for participating. Goodbye.
Thank you. Bye-bye.
Bye.